Hello. I'm sorry. My dogs are going nuts. I wanted to talk to you for a few minutes about medication-induced movement disorders, and other adverse effects of medication. So first, the majority of these are typically in relation to antipsychotic medications. And the psychiatrist that is prescribing the medication usually looks for these symptoms every time that they see the patient. I'm not going over all of them. Let me share my screen here. There we go. Share. Okay. I'm not going to go over absolutely all of them, but I am going through most of them and highlighting some of what you would want to know about it. The DSM talks about how these are not mental disorders, but because they're in relation to medications often prescribed to deal with mental health, we need to be mindful of them. So the first one is tardive dyskinesia. And this one you have probably heard of if you've worked in any kind of mental health clinic that also provided medication management. I've got some notes here for me because some of these are very similar. So tardive dyskinesia involves involuntary slow movements or irregular jerking movements enduring for at least 4 weeks of the lower face, the jaw, the tongue, and extremities. Symptoms manifest during exposure to an antipsychotic medication or other dopamine receptor blocking agent, or within 4 weeks of withdrawal from an oral agent, or 8 weeks from a long-acting injectable agent. The individual must have taken the medication for a minimum of 3 months, or 1 month if they're age 60 or older. Tardive dystonia is an atypical and long-lasting contraction of the muscles in the head and the neck, and in some cases the limbs or trunk that are tardive, meaning that they manifest late in treatment, develop slowly, and may endure for a prolonged interval after ceasing the administration of an antipsychotic medication or other dopamine receptor blocking agent or reducing its dosage. And so, to be clear, because we don't really cover it that much, sometimes not at all, in psychopathology, when they're talking about dopamine receptor drugs, any antipsychotic is looking to block specific dopamine receptors in order to reduce dopamine activity, because there's a long-held theory that there is a dysregulation of dopamine in disorders that can cause varying degrees of psychosis. And when, of course, they tried these sort of anti-dopaminergic drugs, when they saw a reduction in symptoms, it just sort of reinforces the theory, if that makes sense. But sometimes these drugs can cause movement disorders, okay? Let's see. The next one is tardive, I'm going to try this, akathisia. Okay, I might be pronouncing that wrong. Just bear with me. This one is agitated, restless, fidgeting type movements that are tardive, meaning, again, manifesting late in treatment, develop slowly, and may endure for a prolonged interval after ceasing the administration of an antipsychotic medication or other dopamine receptor blocking agent or reducing its dosage. Then we have medication-induced postural tremor. And this one is a fine tremor that occurs when the individual tries to maintain a posture, and that manifests in association with the use of medication. You've also got medication-induced Parkinsonism. These are muscular rigidity type symptoms, difficulty or inability to move and or slow movement. Parkinsonism tremors, like pill rolling tremors, are less common and may not be present. These symptoms typically manifest after a few weeks of beginning a medication or altering its dosage. And then we have medication-induced akathisia. Oh no, wrong one. Medication-induced acute dystonia. This is what I get for having excessive notes and then not putting all of them on the slides. So medication-induced acute dystonia. This one is atypical and long-lasting contractions of the muscles in the head and neck, and in some cases, the limbs or trunk. Symptoms typically manifest within a few days of beginning a medication or altering its dosage. So typically, if you're treating a client who has regular use of antipsychotics, they're going to be seen by a psychiatrist who's going to be checking for these types of things. So why would you need to know? Let me stop share for a second so I can see you. There we go. Because this can be really stressful for individuals. It can cause a great deal of distress in social situations. It can cause damage to their self-esteem because people look at you like something's wrong with you when you have a tremor, right? I have cervical dystonia, yeah, I'm constantly having to try to explain it and help people understand that it doesn't affect my cognitive abilities. I'm naturally scatterbrained, been that way my whole life. That's thanks to my ADHD. But it can increase stress, which could also amplify the effects of the movement disorders. And there's one more thing that I want to clarify. Antipsychotics are not the only drugs that can cause movement disorders. Most people aren't aware of the fact that antidepressants can do the same. SSRIs and SNRIs. They can cause all of these types of issues. The most common is the Parkinsonism, some type of, they call it an essential tremor, which is sort of like when your head only kind of nods no, but there's no like differences in muscles in the back of the neck or anything like that. And they've also been linked to cervical dystonia, and there are a few others. And it's interesting to me that these are things that aren't regularly checked by psychiatrists. And I think it's potentially because it happens in about 2 to 2.5% of the population. And you can get antidepressants prescribed by your general practitioner, who likely also isn't looking to see if there are any movement disorders developing. And these can develop immediately with the SSRIs, and they can develop over time. And it's unclear right now, according to the research, if these go away when the SSRI is removed. So how can something that regulates serotonin have similar effects as something that regulates dopamine? So here's the theory. The serotonergic system and the dopaminergic system, those two neurotransporter systems, they work in tandem together. So dopamine and serotonin are both neurotransmitters as well as what we call neuromodulators. That means that they are also regulating other neurotransmitters, okay? When SSRIs create and SNRIs, when they create an overabundance of serotonin in the serotonergic system, it's theorized that it creates dysregulation in the dopaminergic system. meaning too much serotonin ends up reducing dopamine. And there's not much more evidence beyond that in terms of really trying to understand it, likely because such a small proportion of the population experiences the symptoms. They're things to be mindful of. And if you want examples of what these tremors look like, you can do a real quick, like go to YouTube and literally, type in the name of the movement disorder. And there you'll find videos where they'll show you examples of the types of tremors that can emerge. And that way you can be mindful of it. So when would this be useful to you? If you ever work on a treatment team, it would be important. You might see symptoms months before the psychiatrist does. Okay. And if you do, as a mental health clinician, you would want to let the psychiatrist know maybe they need to come in sooner. Okay. And how does this affect treatment? It depends. It really depends on whether or not they continue the current drug treatment and try to treat the tremors with something else, whether they try to stop the drug treatment and change it to something else, whether they try to take a break altogether. It really depends. It depends on how severe the mental health issue is that the individual was being treated for. And it depends on the particular type of movement disorder that manifested and what they're going to do. I have seen many, many clients who have movement disorders that developed because of antipsychotic medications who did not stop the antipsychotic medication. And instead, they tried to employ other interventions to manage the movement disorder that manifested, because the symptoms that the client experienced when they weren't on the medication far exceeded in severity and damage to the individual than the movement disorder itself. Okay. So just a little caveat, you typically aren't going to diagnose these types of things, but if you notice it, you would make a recommendation to the psychiatrist and say, hey, we need to take a look at this. If they're being treated by a medical doctor, like a general practitioner, family medicine, something like that, and it's not an antipsychotic, because you can get something that isn't an antipsychotic from a general practitioner, and you're seeing something and you're thinking, I'm wondering if this might be related to it, you might need to make a referral to a psychiatrist so that they can check it out. They are absolutely trained in this. They're very good at identifying these issues when they emerge, and they have their own set of protocols. It's sort of like a decision tree of how to figure out what's the best thing to do to move forward. Okay, that's part of their medical degree training once they specialize, right? Okay, so that was it about medication-induced movement disorders, and I'll see you in the next lecture. Thank you for listening.